Hi, everybody. This is Dr. Bernstein again with our November 2015 teleseminar. Before we get started, I want to give you the usual warning that I'm answering questions and my answers are guesses. And without getting a history and physical, as is commonplace in medicine, I can only speculate on what the condition of the individual is and what the treatment might be and so on. So what I should be saying is might throughout the answers to each of these questions, and I might leave the might out, but it belongs there. So don't take these answers as hard answers. They're just possibilities. And they're intended for all of the listeners, not just the one person who sent in the question. Our special subject for tonight's broadcast is, and I'll read the title of the paper from the current edition of Lancet Endocrinology and Diabetes. In fact, I think it's called Lancet. The website is lancet.com, diabetes-endocrinology. This is a major journal, and I'm going to read you the title of the article. New insights into the variable effectiveness of levothyroxine monotherapy for hypothyroidism. What that title means is that just giving T4 thyroid hormone, the most common brand is called Synthroid. There are other brands like Levothyroid. Just giving Synthroid to treat hypothyroidism may not be effective. And then they go into details and they speculate on how many people would there be where just giving T4 is not adequately effective. And they don't really know. But what they're advocating is that there be a large-scale study of the methodology for treating hypothyroidism that I've been advocating for about 30 years. And number one, do not use the serum TSH level as a guide to the thyroid status, because it does not reflect the T3 levels throughout your body. It only reflects the T3 level in the pituitary gland. Therefore, it really is not a good marker for hypothyroidism. And they point out that the serum-free T3, which is what we advocate you measure, is the best indicator of thyroid status. And then they point out that for many people, and in my case, I think for most people, the treatment for low thyroid should be T3 replacement, because that's usually where the major deficiency is. And you've heard this on these teleseminars for years. I've said these things. And finally, the journal Lancet is advocating large-scale clinical trials to see if what I've been saying is really the case for most people. They're saying that there's a lot of evidence that it's the case for many people, but they have no idea how many. So this just reinforces what I've been saying all these years. Hypothyroidism is grossly mistreated, not just in the USA, but probably throughout the world. Now we'll get to our questions. I've read your book and have started your diet. After a couple of months, the health of my teeth has deteriorated. How does the body get all relevant nutrients while excluding major food groups? Well, this person thinks that maybe our meal plan guidelines are taking away nutrients. Now, in reality, compared to what patients in the USA have been doing, at least those whom I've seen, we are, for most of them, introducing vegetables. Most people in the USA are eating packaged foods, cereals, pasta, the list is endless, and eat relatively few vegetables. And in our meal plans, if you look through my diabetes diet book, or even in my book Diabetes Solution, you see that we're pushing vegetables, if possible, at every meal. And I even give explanations in the book that how I came upon the idea that maybe people need vegetables. So we're adding nutrients that most people in the USA are not getting much of. What are we taking away? We're taking away sweets and rapid-acting carbohydrate. Now, that would mean eliminating sweet fruits. Biological fruits that are not sweet, we still incorporate, and biological fruits are the things with the seeds, like cucumbers and avocados and squash and so on and so on. There's a long list. So we're not eliminating biological fruits. We're eliminating those that were deliberately bred or in effect adulterated over the centuries in order to give them a sweet taste. This has been done with fruits just like roses and tulips have been modified over the centuries to give them beautiful colors. So just that the fact that we're eliminating sweets doesn't mean we're taking away essential nutrients. Likewise, for what people call whole grains, which are actually artificial products that are man-made, that did not exist in Paleolithic times, did not exist while humanity was evolving. Humanity did not grow or evolve on what they're now calling whole grains. These are things that raise blood sugar very rapidly. And you could look at the video of me demonstrating how just chewing a little piece of whole grain bread and spitting it on a glucose test strip turns the strip black, indicating that I've made pure glucose just by mixing bread with my saliva. So you cannot blame removal of nutrients for your teeth. If anything, you should have been adding nutrients. Now, why you have bad teeth, I don't know. It usually takes a long time for tooth problems to become visible, years and years. And I find that of the new patients that walk into my office, whom I've never seen before, the great bulk of them already have had root canal treatments and gum problems. So this is before we ever change their diet, and I suspect that the problems are caused by the high blood sugars and for the large amount of sweets that most people are eating in their diets. Next question. Is the blood sugar response from sugar alcohols in a diabetic individual different in any way from that of the non-diabetic person? I would say absolutely. If you give a candy that is sweetened with sorbitol to a non-diabetic, and let's say you give him one piece of one of these hard candies, they're called Sorbies, you get them in the drugstores, they're marked for diabetics. If a diabetic eats one of those, over the next few hours, his blood sugar will go up about 15 milligrams per deciliter just from one little hard candy. It's a little tiny one. And a non-diabetic will probably have no change in blood sugar. The non-diabetic makes enough insulin in response to the sugar alcohol's effect upon his blood sugar so that his blood sugar doesn't really change. But the diabetic will not instantly respond with insulin. The sugar alcohols take a while to work. They're not very rapid acting, but they do raise blood sugar. And if you eat a number of these candies, your blood sugar will go up by a lot. Next question. Do you have any testimonials of people who have recovered from brittle diabetes, the roller coaster blood sugars, using the methods in your book? There are not any patient stories in your book. And this question is from Norway. And my book was published in Norwegian, and it could be that the Norwegian publisher left out the chapter where we have 13 stories from 13 patients telling how they escaped the roller coaster. So yes, it is in the book, but there's another more direct source. If you go to Google or Facebook and type in the words type 1 grit, G-R-I-T, you will get a site with testimonials and visual documentation from many type 1 diabetics, hundreds, maybe even thousands of type 1 diabetics who have followed the regimen of my book, Diabetes Solution, and are now publishing the computer display from their continuous glucose monitors that are constantly sensing their blood sugars. And you'll see how they go from roller coaster printouts to virtual straight line, horizontal line printouts, usually well within the normal range. So we have testimonials, and you can get it for yourself. So again, Google or Facebook, or probably any search engine you choose, type 1 ONE grit, G-R-I-T. Okay, my 14-year-old son was diagnosed September 2014 with type 1 diabetes. He is on the low-carb diet, but does not need insulin to keep blood sugar normal. He is 5'6" and weighs 121 pounds. Trying to eat more calorie-rich foods, but it is not helping him gain weight. Should he continue to be on the low-carb diet? A good question, and one we frequently get, or at least should get, because the American Diabetes Association is pushing people to eat a lot of carbohydrates. Now, why is this fella not gaining weight? Let's look back at my own personal story and the story of millions of other type 1 diabetics over the years. In November of 1945, started drinking a lot and peeing a lot and losing weight. I was after my parents for several months, pleading with them to send me to a doctor. I knew I was sick, and they said, well, you were too fat, so it's good you're losing weight. And finally, when they sent me to a doctor, they found that my blood sugar was 750, and I had type 1 diabetes. Now, why did I lose all that weight? I lost 20% of my body weight. What did I lose? I lost fat and I lost muscle. And I explain this in my book. And the reason was I did not have enough basal insulin. I was making almost no insulin, which is why I was dying. And you need insulin to build both muscle and fat. And no matter what you eat, if you don't have enough insulin, you're not going to grow and you're not going to gain weight. So my guess is that although this type 1 person has very early onset and is still making some insulin, he's not making enough insulin to maintain his body weight, and he probably needs perhaps basal insulin to maintain his body weight. Now, I can't tell for sure. I'd have to see his blood sugars. He may only need insulin before meals in order to utilize the nutrients in the meals. So if his blood sugars go up after meals, he needs mealtime insulin. If his blood sugars go up overnight while he's fasting, he probably needs basal insulin, or he may need both. He may need very small doses, but without adequate insulin, you cannot grow or gain weight. Next question. Can raising long-acting insulin levels actually cause or trigger bouts of diarrhea such as I experience in the days since raising my insulin dose on Levomir from 48 units per day to 60 units per day? Well, this question doesn't have obvious answers because I don't have a lot of information. But one real possibility is that this person has a gastrointestinal infection and causing the diarrhea, but infections also cause insulin resistance and can cause tremendous increase in insulin requirements. I see many patients where out of the blue, all of a sudden their insulin requirements go up and we search for an infection, and usually we find the infection right away. Most often it's in the mouth, but it could be elsewhere. And my bet is that the infection that caused the increase in the Levomir dose also caused the diarrhea. Now, I could be wrong, but that's my guess. Another possibility that one should think about is inadequate levels of the immunoglobulin IgA. That's fairly common amongst diabetics and should be investigated. That can cause diarrhea, but it can also increase your susceptibility to infections. I am a 63-year-old male with type 1 diabetes. I exercise 5 days a week. My testosterone level was 181 at my last blood test a month ago. I exhibit 3 of the clues mentioned in your book, plus experience lethargy and fatigue after exercise. Would I benefit from testosterone therapy? Well, nowadays, the pros and cons of testosterone therapy are so complicated, the scientific literature on it is changing so rapidly that instead of prescribing it myself, I now send people to reproductive endocrinologists who specialize in low testosterone levels. There's a real possibility. First of all, this person didn't mention whether this was his total testosterone or free testosterone. Usually the bottom of normal for free testosterone is 400, and that does not signal automatically give testosterone replacement. One asks about symptoms, and this guy has symptoms, but he may be hypothyroid, and that may be responsible for his symptoms. So the very first thing one should do is check his free T3 levels to see if he's hypothyroid, correct the hypothyroidism if that exists, and if he still has symptoms, then he can consult a reproductive endocrinologist. Next question. Type 1 diabetic for 33 years. This person is a survivor. My endo wants my blood sugars at 8 millimoles after 2 hours. 8 millimoles per liter is 8 times 18, or let's see, 80 and 64, 144 milligrams per deciliter, which is a little below double normal. So here we again have the endocrinologist wanting the patient to have high blood sugars. Isn't this too high? Right now they average 6, which would be 108 is his milligrams per deciliter is his average blood sugar. Still a little bit high, but not so high that it will rapidly cause the long-term complications of diabetes. My endo says I am too controlled. What do you think? Well, we're back to the old story, and I've repeated it over and over again. I've been told this by endos who are responsible for the guidelines or were responsible. And I'll repeat it because it's so important. I'm an endo. I specialize in diabetes. I have 3,000 diabetic patients. I don't have time to get deeply involved in the treatment of each one. So their treatment is approximate, and I know that they're going to develop the long-term complications of diabetes. Are going to, some will go blind, some will have kidney failure, et cetera, but those are natural consequences of diabetes. I cannot be blamed for those. But if one person dies of hypoglycemia, I can get sued. To make things even more complicated, if I get sued, but I was following the ADA guidelines and recommending high blood sugars and high carbohydrate diets, I'm going by the guidelines, and the laws of most states in the USA say that if you follow the guidelines for your geographic area, what you have done may cause a death, but if you've been following the guidelines, you're not responsible. So if I follow the guidelines, doesn't matter what happens to this guy, I'm not responsible. That's how I get off the hook. And that's why you're being asked to have high blood sugars. That's my guess. Would you recommend autoantigen specific immunotherapy for early stages of type 1 diabetes? This is a new approach to treatment that's being tried on rodents experimentally. It's not anywhere near being available for humans, and in fact it has not been demonstrated to be clearly successful on humans, so there's no reason to be thinking about it right now. If the time comes many years down the road when it's approved by the FDA, then you start thinking about it. Next question. Is successful married life possible with a type 1 diabetic male? What factors should one consider in marrying a type 1 diabetic person? And this is sent to us by a woman. And indeed, you have to be concerned, I guess, what she's thinking about is the erectile dysfunction and the inability to have children that eventually occurs if you have chronic elevated blood sugars for years. In fact, back in 1956, when I got married, before we got married, my doctor, who is a diabetologist, warned my wife that we should have all of our children before the age of 30, because after 30 I would not be able to have children. Well, our last one was conceived when she was 39 and I was about 42, and we have a collection of children, one of each, total of 4. And that was because I had worked out how to normalize my blood sugars before the last one was born. So if you go buy my book, Normalize, I didn't mean go BUI my book. I meant go BY my book. Use the methods. Keep your blood sugars normal. You don't have to worry about the erectile dysfunction. As far as other aspects of marrying a type 1 diabetic, if they're poorly controlled, you're going to have to worry about the patient going blind. You're going to have to worry about all kinds of bad sicknesses, and it would be a very unpleasant situation for the both of you, whether he's married or not. But if he follows the guidelines in the book, your life can be close to that of a non-diabetic. And again, visit the Facebook page for Type 1 Grit to see what can be accomplished, or visit it on your search engine on Google, etc. Do you recommend 30 grams of carb per day for a 3-year-old? Absolutely not. I recommend much less. I recommend that it be stepped down in proportion to the body weight. If 30 grams per day will raise the blood sugar of a 150-pound person by about 150 milligram per deciliter over the course of a day, unless it's covered by insulin. For a person who weighs only 30 pounds, it'll raise their blood sugar by 720 milligrams per deciliter over the course of a day. This is a huge effect on blood sugar. And little kids cannot tolerate that. So they require much less carbohydrate. And these are the ones that survive without the impairment of cognitive function that occurs in children who have had high blood sugars for years. Next question. My free T3 is 1.8, which is below the bottom of normal, which is 2 to 4.4. Fecal anti-gliadin IgA is 68. Normal is less than 10. Okay, this person is worried about celiac disease, and he is making antibodies to celiac disease, and these antibodies are present in his stool. This suggests dietary gluten sensitivity, but the person who asked the question has not stated that he has diarrhea. So we don't know for sure that he has celiac disease. Other immunoglobulin tests are in the normal range. What should be done about the elevated fecal IgA? Well, if you have symptoms, you go on a gluten-free diet. And you might want to see a dietitian who specializes in this. You might want to see a physician who specializes in celiac disease, or you might want to look on the internet for gluten-free diets. Now, the diet we recommend in my books tends to be gluten-free because we eliminate breads, but there are other substances, processed products that contain gluten. For example, instant coffee is a source of gluten. You wouldn't expect that, but yes, it is. So you have to go to lists of high gluten foods. That's if you're getting diarrhea. But your main concern, I would think, is the low T3. And I would expect that you would have symptoms of low T3, such as fatigue, impaired cognition, etc. High lipids, high other cardiac risk factors. That would be my main concern, because I don't even know that you have any symptoms of celiac disease. Next question. There seems to be significant scientific research supporting the connection between gut permeability and autoimmune disease, and that restoring the healthy gut microflora can have a beneficial impact on autoimmune disease. What are your thoughts on this? I think that there is accumulating evidence that this is indeed the case. And I have seen some studies published, I think in the journal Diabetes, but I'm not certain, that obesity, for example, causes increase in inflammatory markers, increased gut permeability, and increased incidence of type 2 diabetes. And that one of the mechanisms for the occurrence of the type 2 diabetes could well be the gut permeability. Now, it's also interesting, as an aside, that CVID, which I've discussed many times, common variable immune deficiency, usually, or I should say frequently, involves low levels of IgA, immunoglobulin A, in the blood. And with low levels of IgA, we frequently get inflammation of the mucosa of the gut with increased permeability. And we find that 25% of diabetics have CVID, and it could well be that this increase in gut permeability for many of those with CVID could be a cause of their diabetes. So these are interesting things to think about. What to do about it, we really don't know. Yeah, if you have CVID, treatment with gamma globulin can be helpful. Next question. I live in the United Kingdom. The insulin manufacturers here say there are no diluting fluids for my fast-acting insulins. Can I use plain over-the-counter water for injections to dilute the fast-acting insulins? The answer is no, but the manufacturers have misinformed you, and I wonder whether you spoke directly to the manufacturers, and if the people you spoke to were really technical people or salespeople or medical people rather than salespeople, because we know that each manufacturer does make diluting fluid for their rapid-acting insulins. I will list the rapid-acting insulins, and I know that each of them has a diluting fluid. There's regular insulin, also called crystalline insulin. It's the insulin with the R on the bottle. There's Humalog, which is made by Lilly, and is also called, and its generic name is Lispro. And there's Novolog, which is made by Novo. Now, both Lilly and Novo make diluting fluid. Novo makes a diluting fluid that covers Novolin R, covers Novolog, and also covers Novolin N, their NPH insulin. The same diluting fluid. Lilly has a diluting fluid that covers their regular insulin, their Humalog insulin, and their NPH insulin. So both these companies are making diluting fluids. In a pinch, you could probably get away with what's called normal saline, NORMAL, which is 0.9% saline for injection. It comes in a sterile vial. Most pharmacies have it, and that can be used for diluting only the insulins that I just mentioned. At present, there are no long-acting insulins on the market that permit dilution. The dilution interferes with their action, which is very sad. We once had an insulin, a long-acting insulin, a fine, excellent insulin, ultra-lenti, and for financial reasons, the manufacturers took it off the market. It was dilutable, and we were treating adults and infants and small children with it, and it was wonderful, but the patient doesn't count anymore, and the insulin makers just took it off the market, never promoted it, so they didn't even let people know that they had it for years. I used it for about 30 years. So you can probably get by with normal saline, 0.9% saline, but the manufacturers do have diluting fluid. Next question. Would blood transfusions help with resetting the A1C for 3 months? You'd have to get a lot of blood, and the hazards of the transfusion would be so much greater than the hazards of the A1C, because the transfusion will not change the glycosylation of proteins in your body. It'll only change the glycation in the red cells, and the damage throughout the body that's caused by high blood sugars would not be ameliorated. The change in the red cells is, for the most part, a marker of what's happening elsewhere. And if you artificially change the red cells, you're not going to do a thing about what's happening elsewhere. So this is not only not a wise course, but potentially dangerous, because you have 6 quarts of blood. You'd have to transfuse 6 quarts, which is almost like major surgery. So I would not even think about this. Do you see a connection between increased cortisol production in the body and elevated glucose levels in type 2 insulin-resistant diabetics? Well, we know that we can inject people with cortisol and raise their blood sugars. So cortisol can raise blood sugar. We know that stress can raise blood sugar, and we know that stress raises cortisol levels. So I have some type 2 diabetics, but more likely type 1 diabetics, who are performers or teachers, and when they are faced with an audience, their blood sugars go up. Again, probably due to increased levels of both cortisol and epinephrine. So cortisol can raise blood sugar, but it's not that high cortisol levels are the reason for the insulin, the routine insulin resistance of type 2 diabetes. It's the mesenteric fat, that is the fat that's under their the shell of their stomach, of their abdomen, I should say, the fat that's over their intestines that causes insulin resistance in type 2 diabetes. And as far as I know, there are not higher cortisol levels in the average type 2 diabetic. There is a disease, by the way, Cushing's syndrome, which is quite rare, where people make too much cortisol, and they can have high blood sugars as a result. That's rare. My Freestyle Light meter seems to read almost 20 points below my provider's meter and leads to a calculated A1C lower than my lab values. Is this accurate? Well, there are several things to consider. First of all, in my experience, most providers recommend meters that are inaccurate. They recommend the meter that gets the most promotion, or that a salesman drops off, or that costs the least. So you have to find out what meter your provider is using. Probably the gold standard meter is the HemoQ. So if he has a HemoQ, I would take his meter reading seriously. Otherwise, I would, if it's a meter you can buy in the pharmacy and it's not either a Contour Next, or a Freestyle Freedom meter, I wouldn't count on it being accurate. In fact, some of the ones in the pharmacies that the endos have are grossly inaccurate. One way to check on your on the reproducibility of your doctor's meter is to do 3 blood sugars in a row and see if they're all the same. And this is true of the Contour Next and of the Freestyle Freedom meters in the vicinity of the normal range, around 70 to 100. So it's a way of double checking. Another way to double check your meter is to get some blood drawn at the lab for a blood sugar and do a meter reading at the same time, but do several meter readings, because your meter readings should be all in the same vicinity. And also, this whole game of checking accuracy is only valid if you're in the normal range, really below 100 or below 110. Now, another thing to look at is an accurate formula for the hemoglobin A1C. The formula being used by the American Diabetes Association is not accurate. I'm not going to go into the details of why it isn't, but we explained this several years ago. It's a shameful situation, but the formula that's most likely to be accurate is in my book, Diabetes Solution. It was published by the American Diabetes Association a number of years ago when an accurate method for estimating it was used. So use the formula that I give in my book. Next question. Does type 2 diabetes contribute to belly fat? Would a tummy tuck help diabetes? Well, a tummy tuck deals with superficial fat, not mesenteric fat that we mentioned previously. Insulin resistance is caused by mesenteric fat, which is under the surface. You cannot grab it, and a tummy tuck cannot reach it. It is under the muscles of the abdomen and is way inside. So a tummy tuck is not going to make any difference. And the mesenteric fat does indeed cause insulin resistance. What are your thoughts on resistant starch? Well, we have discussed this indirectly when I spoke about the low carbohydrate bread that I sometimes use. It contains a resistant starch. There are a number of resistant starches, one of which most commonly known one is called the Inulin. It's like insulin without the S. And these things do raise blood sugar, but they raise blood sugar very slowly. So slowly that you can cover them with regular insulin injections, which are relatively slow compared to things like Novolog and Humalog, but are much more predictable in their effects. So the resistant starches will raise blood sugar. You have to do computations and trial and error to see how you'd cover them. And there are better ways of getting snacks, such as eating protein foods. But you can use these things and you can make them work, but it takes experimentation. And you have to, if you're type 1 diabetic, you have to cover them with insulin. With type 2, you can't just eat them continually because it's going to add up like a protein food would. Eventually your blood sugar will go up if you eat enough of it. I am interested in knowing about type 1.5 diabetes. What does it mean? Well, it's a term it's an unofficial term that really has no meaning, and different people have made it up to apply to different situations. Most commonly, it applies to people who make a little bit of insulin or a moderate amount of insulin, still may need small insulin injections, but don't need total insulin replacement as most type 1s do. So it could be a term that is used to describe early type 1 diabetes. It could be a term that is used to describe advanced type 2 diabetes. It's not a real term that's been defined medically, and it's like a play term that people pull out of the air. And as I said, when I've spoken to the people who've used the term, they mean that these people are making some insulin, but may need a little bit of injectable insulin. There's another term called LADA, latent autoimmune diabetes of adults, and that's been sometimes called type 1.5, but that's a real type 1. It just occurs at a later age, so it's not, you can't legitimately call it 1.5. Then people have used the term 1.5 to describe people who are originally type 1 diabetics and then became obese and insulin resistant. By the way, that's usually rare because if people are already diabetic and eating enough excess carbohydrate to become obese, they would have very high blood sugars and would have trouble getting fat. So that would be a strange combination. Okay, let's see what else we have. If I draw air through syringes as I use them, and then air dry syringes for a year before I reuse them, is there a chance of polymerization of old insulin? Now, what this person is referring to is something I've pointed out in my book and also on these teleseminars, that insulin in fine needles polymerizes. And if injected back into a vial, will act as a seed for more polymerization in the rest of the vial, over time spoiling the insulin in the vial. Now, what happens if you let the polymerized insulin coat the inside of the needle for so long that the polymer becomes hard like an egg, not like the shell of an egg, but like a cooked egg? Well, then it will not come off the lining of the needle and get into the vial when you draw more insulin in, and may not cause subsequent polymerization. So I don't know what happens in there if it dries real hard, if you let it sit there a long, long time. But if you let it sit there a few hours and then inject it back into a vial, you're going to cause problems. So this person wants to get his needles thoroughly clean on the inside. Let's assume that. What I would do is flush them with sterile water, which you can buy in a pharmacy, and let them sit around till they dry. And then what you're leaving coating the inside of the needle will probably evaporate over time. Of course, if you have a cover on the needle, it might not evaporate, so I can't be sure. But I would recommend sterile water if you want to flush it and save the syringes. Or you could flush it with sterile water and reuse it again soon. You don't have to wait a year, because the little bit of water that is left in the syringe, if you inject that back in the bottle, it's such a microscopic amount and there's no insulin left, it's not going to do any harm. You just want to make sure it's sterile. Okay. How do I know my pancreas is making enough insulin? Well, if you know you're not diabetic and don't have elevated blood sugars, your pancreas is making enough insulin. If you want to be challenged, you could have an oral glucose tolerance test. And there are guidelines that determine whether you have impaired glucose tolerance, elevated. There's another test called elevated fasting glucose, which you could take. You just check your blood sugar when you get up in the morning. So you could also check a fasting C-peptide, but that doesn't tell you very much because it only applies to the fasting state. And to find out if you're making enough insulin, you want to know how you respond to meals or to glucose. So getting a glucose tolerance test is probably the most precise way. It's also the most traumatic because you have to consume a lot of glucose and get frequent blood sugars. Another thing you could do is check your blood sugar 2 hours after meals. That's not a precise way. In some people, it is. For example, my mother never had a blood sugar. She lived to be 95. She never had a blood sugar that exceeded 100, no matter what she ate. And I once gave her a glucose tolerance test where going over 200 is a marker of diabetes. Her highest value was 137. So for a person like that who never goes over 100, you could be sure they're making enough insulin. But I gave you several options. Do you think using an iPad or smartphone diabetes app will help with diabetes control and help prevent diabetes complications? Well, an app is not going to normalize your blood sugars. It would have to be the length of my book. And the book is out there already, and it tells you what to do step by step. And here we, if you go to this Type 1 Grit Facebook page, you'll see thousands of people who have used the book, who are people who are into electronic devices and big on apps, but it's the book that's changed their lives. There are no formulas that work for controlling blood sugar. The formulas that have been programmed into insulin pumps, for example, have not worked. And that's why I've never seen a well-controlled pump user. Most of the apps that are already out there are telling people to eat a lot of carbohydrate and use this app to calibrate how much insulin you must inject to cover the carbohydrate. Trouble is that large amounts of carbohydrate lead to large insulin doses which are unpredictably absorbed. So read the book. I am 66 years old and a pre-diabetic. I found your book and have applied your methods. My blood sugars range 80 to 100 milligrams per deciliter, averaging in the mid-90s. Now, right away, one wonders what meter is this person using, because meters can be 100% off on their numbers. My A1C in June was 6.3%, which is an average blood sugar, I might add, of 152 milligrams per deciliter. So that doesn't jibe with blood sugars being between 80 and 120. Something is wrong. I lost 35 pounds since last October and am now 259 pounds. What can I do to keep losing weight? Well, first of all, you should really follow my book. And right now, there's something wrong that you're doing if your blood sugars are so different from your hemoglobin A1C. You may be eating more carbohydrate than the book recommends. Certainly, the 6, 12, and 12 grams of carbohydrate for the 3 meals would apply to you, and my guess is that you're not following that. But I'm not sure. Next question. In your book, you mentioned that as a young man, you had difficulty gaining weight. Why was that the case? Well, at this point, I should say to everyone out there, what's your guess? It's, of course, the fact that I did not have enough basal insulin to maintain my muscle mass and my fat mass. I was diabetic. Before I became diabetic, I was overweight. So I had no trouble maintaining weight. I was too fat. But once I was diabetic, as with all of the other type 1s, I started losing weight. That's what happens. And then when you normalize blood sugars, you start growing again and you start putting weight on again. I'm not saying wait to get fat, but getting back to your normal growth curve. Next question. Despite normal electrolytes and 500 milligrams of no salt at bedtime and drinking chicken bouillon daily, I am still getting almost nightly leg cramps after 6 months on your regimen. Any suggestions? Well, first suggestion is if you're taking a statin drug, that can cause nocturnal leg cramps and even more severe kinds of muscle cramps. But most common is deficient thyroid levels, in particular free T3. So what I would recommend is that you have your free T3 level checked. Sometimes when people lose weight or eat less carbohydrate, their T3 goes down and they need T3 replacement. And that's what I would do. And that's it for today.